The International Agency for Research on Cancer, we are the WHO's Cancer Research Cancer Policy Organization, and we are working on updating the European guidelines on cervical cancer screening. I'll describe the recommendations that we have come up with, but also will give you the evidence that is supporting those recommendations. And at the outset, I must thank the excellent working group of experts that we have coming from all the different parts of Europe to guide us and take us through these recommendations. And two of those experts, Dr. Urska Ivanus and Dr. Paolo Rossi, they are here. Thank you so much. What we did was we first identified the different healthcare questions that we need to address across the continuum of cervical cancer screening, starting from identifying the test, the age to start, age to stop, interval of screening, going right up to triage, and then management of cervical precancer. It's a stepwise process. And for each healthcare question, we followed the very well-known GRADE methodology. That means we came out with the PICO questions. What are those? What is PICO question? I'll come to that in the next slide. Say, for example, we first tried to identify what will be the appropriate test for the women. Now, to do that, we already had the last European recommendation published in 2015. The European recommendation in 2015 already recommended HPV test over cytology in the women between the age of 30 to 59 years. Subsequently, in 2021, the WHO strongly recommended HPV test over cytology for 30 to 49 years of age of women. So there was no point trying to come up with the same evidence and same kind of recommendations. So we took that let us take the HPV test as the the intervention that is already recommended and compare other interventions to it. So we compared cytology, we compared co-testing with HPV detection test. And for each question, as I said, we had the PICO, that means population. The target population is women with average risk participating in an organized screening program. The intervention, as I said, will be either cytology or co-testing, and comparator will be HPV testing, and we looked at the several outcomes, and I'll come to them one after another. First thing we did was updated this evidence that was already there in the 2015 recommendation. There were several randomized controlled trials that showed that if you have HPV-based screening in the first round, you detect more CIN2, CIN3 cases, so that in the subsequent round, the number of CIN2, CIN3 cases detected in the HPV screening arm is significantly lower as compared to the cytology arm. So you can see on the right-hand side, this is showing the CIN3 plus incidence in the second round of screening in the HPV arm versus cytology arm. And you can see the significant reduction in the second round of screening to the extent of 56%, significant reduction there. We also looked at the reduction in cervical cancer incidence with HPV screening as compared to cytology. Again, you can see the significant reduction in the cervical cancer incidence. So this strengthened the recommendation that HPV screening is much more effective as compared to cytology screening. So we have a full evidence to decision table. If you can go to the EC-CvC website and look at that. But I'm just trying to give you some of the gist of that. For example, if you look at the first row, it is showing the detection of CIN3 at the first round. And you can see HPV testing detects significantly higher number of CIN3 cases at the first round. Or rather, if I say the other way around, cytology detects much less CIN3 in the first round. And because of that, in the second round, in the cytology screening arm, more CIN3 cases are detected. So the prevention effect is much less with cytology as compared to HPV. And also we looked at the undesirable effect. So desirable and undesirable effect. So on one hand, with cytology screening, you are detecting less number of CIN3 cases, less number of invasive cancers. But yes, there can be some benefit. The benefit is that with cytology, there are less number of colposcopy as compared to HPV. But that number can be reduced if I go for a proper triaging. We also looked at co-testing compared to HPV screening. And there is no randomized control trial, but there are evidence coming from non-randomized studies that shows, yes, with co-testing, there will be a few cases of CIN3 plus detected, but the number is very trivial. On the other hand, there will be more colposcopies, more resource requirement, which is undesirable. And in fact, we did there was a modeling study that showed that with co-testing, there is no excess reduction in mortality as compared to HPV screening. And there is also data coming from studies like Miriam Elfstrom did. These are the women who were at the baseline, they were positive for HPV testing, cytology testing, or for co-testing. But they didn't have disease. And over the time, as these women were followed up, you can see in the cytology arm, they keep on getting, they were all negative on the screening test, no disease. And over time, cytology negative women, they keep getting disease. Whereas HPV negative women or co-test negative women, the disease incidence is very low, and there is no difference between co-testing line and the line that is going for looking at HPV screening. So over the interval, the protection offered by co-testing is same as with HPV testing. So there is no advantage of co-testing, whereas the undesirable effect is more colposcopy and related harms like overtreatment. Next question so the final recommendations from the working group was, number one, it recommends using HPV testing for primary screening in asymptomatic populations aged 30 to 50 years. So that is the minimum age we started with. It recommends not using cervical cytology. It recommends not using co-testing. Now, we have looked at 30 to 50 years age group. Now we try to see what is the benefit of screening the 25 to 29-year-old women. First thing we looked at was, what is the burden of disease? Yes, even in these young women, there is a significant number of cervical cancers being detected in different European countries. There is some variation, but then you can understand that the burden is significant. So we need to screen them. Now, performance of cytology versus HPV test in this age group, again, evidence coming from randomized control trial is very clearly showing that cytology detected less CIN2, less CIN3, and invasive cancers as compared to HPV testing. So this is the evidence coming from randomized control trial. And then when we summarize the evidence that to understand whether we should screen the women starting at 25 years with HPV test or with cytology, because in Europe, many of the countries, 25 to 29-year-old women are offered cytology-based screening, and then they switch at the age of 30 years. So we try to see what if we start at 25 years with HPV testing. And the observational studies, they show that with HPV testing, there will be increased detection of CIN2+, there will be increased detection of CIN3+ in the first round of screening. Modeling studies also showed significant reduction in cervical cancer mortality if we screen this group of women with HPV testing compared to cytology testing. So, but then there is a small to moderate undesirable effect. We all understand that there will be more colposcopies in the young women, but then that can be reduced by effective triaging. The resources required were considered to be moderate. So looking at this balance between desirable and undesirable effects, the working group recommendation is primary screening using HPV detection tests in populations aged 25 to 29 years, starting with HPV detection tests and right from the age of 25 years. You don't have to wait till 30 years to switch to HPV testing. What about women who are younger than 25 years? So there was, we looked at is there any desirable effect? There is no significant reduction in cervical cancer in observational data in these young women. In any case, the burden of disease is very low in these young women. Small decreases in incidence in mortality on modeling study was found, but the undesirable effect was too much. 9,223 extra colposcopies per 100,000 women screened in this young age group was considered to be a very significant undesirable effect. And that is why the conclusion was that there is minimum benefit with substantial harms. Do not start screening before the age of 25 years. So that's the recommendation. What about the upper age group? We looked at first the 50 to 64-year age group, if we extend the screening at that age group. Yes, in this age group, the burden of disease is significant, and then there are additional CIN2+ detected that's considered as a large desirable effect. Modeling studies show that ending screening at 65 years compared to 55 years, compared to finishing early, is associated with 26 fewer deaths compared to 100,000 screened women. There is a small undesirable effect, which is 28 per 1,000 additional recalls to colposcopy. As you can well understand, this number is not huge. And there will be certainly a little more resources required. What about extending to 69 years of age? Yes, there is again a small desirable effect if we extend this to this age group. But then there is moderate undesirable effect, which was recalling these women for colposcopy. But then what is more considered was the feasibility. We all know the difficulties of doing colposcopy in these elder women, difficulties in doing any procedure in these elder women, and then cost effectiveness also favors stopping at the age of 64 years. So the recommendations are continuing screening in asymptomatic populations until 64 years of age with HPV detection test. Suggests against cervical cancer screening in asymptomatic population with the cervix aged 65 years or older. It does recommend stopping at the age of 65 years, but there is a remark. Women who have not been systematically screened, even if she is 65 years or older, she needs to be screened. So that is the message that came out from the recommendations. So the age recommendation currently is 25 to 64 years of age. Screening test is only HPV test with appropriate triaging. And now we looked at the interval between two rounds of screening. To do that, we looked at the risk of incident CIN3+ in the screen-negative women. There are several longitudinal studies that have looked at that with cytology, with HPV test, with co-testing. Now, you can see, if you look at the topmost graph, you can see the color differences. The blue color is what is showing the risk. That means, and then at the line at the bottom, it shows over the years. So you can see that women who are cytology negative, around the age of 4 years, around the interval of 4 years, the line starts going up. So the risk goes up. So if we take 0.5% risk of CIN3+ disease as the cutoff, with HPV test or co-testing, we can wait further. You can see easily we can wait till 10 years. And then if we take the cutoff as lower, you will have to 0.125, you will have to start rescreening after 5 years, even for those who are HPV negative. But the European experts, they wanted to stay in between. They took a cutoff at 0.25% and tried to see at which interval this cutoff is exceeded. And you can see that we can safely wait for 6 or 7 years. But there was some more evidence. We saw that the risk was different by the age groups. In the younger women, less than 40 years, if you compare 5 years versus 10-yearly screening, you can see we are detecting there are more cases of CIN3 and also cancer because we have extended the interval from 5 years to 7 years. So extending the interval from 5 years to 7 years, in the young women below 40 years, there will be 1.4 per 1,000 screened. There will be CIN3 cases will be missed. 4.6 per 1,000 cancers will be missed, so which was considered as not acceptable. So in this young age group, they decided, let us stick to 5-yearly screening. On the other hand, if you look at the 40 years plus age group, these numbers are almost very minimum. Even for cancer, it is 0. So that is why the recommendation is that it's different between the age groups. If it is less than 40 years, we have to stick to the 5-yearly interval. If it is 40 years and above, we can extend the interval to 7 years. Till now, all these data, all these evidence, all these recommendations for unvaccinated average risk women. Now, in Slovenia, women who are vaccinated, now they are coming for screening. So we need to come out with a recommendation for screening of the vaccinated population. As you well understand, there is not enough data from studies, randomized or observations, so we had to depend on microsimulation modeling to address these questions. So we looked at the population, and we considered the variability that is there in terms of coverage of vaccination, in terms of the type of vaccine that has been used, in terms of the background risk in the population. Say, for example, in some of the East European countries, the background risk is much higher because the screening has not been implemented properly in those countries. So we looked at, to understand background risk, we looked for HPV 16 prevalence in the 25 to 29-year-old women. If it is, and we took 6% as the cutoff. If it is less than 6%, it was considered less risk, 6% and above, high risk. So that's how we looked at the population. And the interventions were, essentially we're trying to see, you start at 25 years, extend it to 10-yearly screening. You start at 30 years, extend it to 10-yearly screening. Or 35 years, extend it to 10-yearly screening. So starting at different age and extending the screening interval to 10 years. That's how we looked at the intervention. And the comparator was what we have recommended for the unvaccinated population. That means 25 to 65 years of age group, 5-yearly screening with HPV testing. So what's the evidence showing in terms of desirable effect? Obviously, you can well understand the main desirable effect of increasing the interval, starting late, will be essentially less number of colposcopies, less overtreatment, less harms related to overtreatment like preterm birth. For the first intervention, it is small. The second one, that is 10-yearly interval, and starting at 30 years, it is moderate, and then it is large for the third one. Yes, as we increase the interval, as we increase the starting age, the desirable effect will be larger. But then undesirable effect, what are the undesirable effects? There will be incidence of cervical cancer, mortality from cervical cancer, and life years lost. So 10-yearly screening, starting at the age of 25 years, you can see all these undesirable effects are trivial. And they are also trivial for the 10-yearly screening starting at 30 years of age. But when we go for starting at 35 years and 10-yearly interval, from trivial they go to small effect. So the working group looked at all those evidences and decided to go for a recommendation that is based on multiple factors. So what are those? First thing, who are we talking about? We are talking about girls who got vaccinated below the age of 15 years in the National Immunization Program and now coming for their first round of screening. So that is the population. Now, the recommendations are dependent on vaccination coverage in that particular cohort of girls who are going to be screened for the first time. If the coverage is less than 50%, doesn't matter what is the background HPV prevalence, just stick to the current recommendation of screening women with HPV testing starting at the age of 25 years, every 5 years. If the vaccination coverage is 50 to 74%, as it is in Slovenia now, and but then in Slovenia, the HPV prevalence is low. If it was high prevalence, then again, don't change your recommendations, just start at 25 years. But because in Slovenia, the prevalence is low, one can consider for the vaccinated population starting at 30 years and doing screening every 30 years. If the coverage is 75% and higher, and the background risk doesn't matter, one can start at the age of 30 years, and screening can be done every 10 years. Now, this is for a population program. Now, what happens? An individual comes to you who has the evidence that she has been vaccinated before the age of 15 years. And for that, what is applicable is the first one. What is applicable is the last one. That means she is considered fully covered. She has, the risk is very low. For her, we don't have to start screening at the age of 25 years. We start at the age of 30 years. We do every 10-yearly screening. So that is the big benefit of vaccination. So with that, I'll stop and we'll be happy to take questions. Thank you.